Pacing spikes. Vertical spikes of short duration, 2 milliseconds. Atrial pacing. 6 sinus with normal AV conduction. Pacing spike precedes P. Ventricular pacing. Chronic atrial impairment, AFA flu. Pacing spike precedes QRS. RV pacing, QRS LBBB. 55 pacing, QRS RBBB. Street T should be discordant. Dual chamber pacing. Heart failure with wide QRS. Atrial pacing, ventricular pacing both. Ventricular pacing, spike precedes QRS. Dual chamber pacing. Tachycardia, SVT, AVRT, AVNRT, VT. Atrial, premature, beats. Common, can be present in normal patients, asymptomatic or palpitations, etc. TX for symptomatic propranolol, catheter ablation. Sinus P wave, P, followed by an atrial premature beat, P, in a repeating pattern, DX atrial bigeminy. Atrial premature beat that is blocked within the AV node and not conducted to the ventricle. Atrial fibrillation. Irregularly regular, no P wave, causes valvular, SMS, thyrotoxicosis, IHD, alcohol, hypertension. 9. TFT, electrolytes, cardiac enzymes, CXR, echo, TX. 1. Rate control. 2. Rhythm control. 3. Anticoagulation. Ashman phenomenon of AF equals long interval plus short interval to set up aberrant conduction, not PVC. Atrial flutter similar causes to AF. Vagal ATP slow down the heart, make flutter more obvious. 9. CXR, electrolytes, TFT, cardiac, enzymes, echo. Rate control. 1. Drugs, digoxin, diltiazem, verapamil, BB, amio, less successful than AF so attempt, rhythm, and higher success rate of RFA. 2. Plus anticoag, CHA2D2 VASC's core, monitor with INR, manage similar to AF. SVT. 9. CXR, electrolytes, cardiac enzymes, TFT. Vagal maneuvers. 1. Cold water, CI, IHD. 2. Valsalva. 3. Carotid massage, CI, carotid brute, adenosine, verapamil, diltiazem, BB. Definitive treatment, catheter ablation. Narrow complex tachycardia. 1. Rate. 2. Regularity. 3. Look at P. QRS. P. QRS equals atrial arrhythmias. P. QRS equals AVRT. P in street segment behind or AVNRT. P fuse of WQRS. P. QRS equals junctional tachy. AVRT, with P wave, retrograde, activation, in street segment. AVNRT, with P wave fused into QRS, segment. ATPQ as AVRT AVNRT. Still see the P waves, that is atrial automaticity, sinus atrial tachycardia. Only see fibrillation waves. WPW. Depolarization reaches ventricle early, via accessory pathway, bundle of, Kent, 1, short PR, 2, delta wave, 3, QRS prolongation, CX torsades, AF, PSVT, where is the AP, dominant R wave in V1 plus no delta, wave in V1 ill-sided AP. 9. Electrophysiological studies. Contraindicated drugs, digoxin, verapamil, metoprolol. Enhanced antegrade conduction through the AP due to increased refractory period in the AV node. Digoxin also shortens the refractory period of the AP, enhancing antegrade conduction. TX, RF ablation of accessory pathway. Pre-excited AF in WPW. Rate, 200 BPM. Irregular rhythm. Wide QRS complexes due to abnormal ventricular depolarization via accessory pathway. QRS complexes change in shape and morphology. Axis remains stable unlike polymorphic VT. HIPIC Pro. Progression. 1. Peak T wave. 2. Prolonged PR. 3. Loss of P wave, broadening of QRS. 4. Bradycardia. 5. Sine wave. Causes: CRF, osce, BB, K plus pairing diuretics, TX, calcium gluconate, dextrose insulin drip, resonium C, diuretics, bicarbonate, hemodialysis. Very broad QRS, 160 ms, plus BBB morphology suspicious of HIPIC. Typical RBBB, 120 milliseconds, LBBB, 140 milliseconds. VT capture beats, fusion beats, AV dissociation. DDX, SVTW aberrancy. 1. VD will have AV dissociation. 2. VT has fusion and capture beats. In SVTW aberrancy there is no connection between AVN and ventricles. 3. If SVTW-BBB, QRS complexes look same in sinus and tachycardia. 4. QRS, 160 ms equals ventricular. 5. LAD equals ventricular. 6. Very irregular equals AF plus BBB. DC cardioversion if unstable, ICD in long run. Brugada syndrome. Street elevation, J-point elevation, T wave changes.
寫話落去未啊？